through the journey of Ponseti technique of clubfoot correction. We have a few interesting cases coming after that. So I'll invite Dr. Meet Jain to take over and moderate the session. Welcome, Kamlesh.
Welcome, sir. Sir, so we have with us today Dr. Kamlesh Devmurari, sir. Sir is a consultant pediatric orthopedic surgeon at Ars Children's Hospital. Sir has done numerous national and international fellowships, and sir is currently the honorary secretary of the Gujarat Orthopaedic Association. He has done a pediatric ortho fellowship from Mumbai and South Korea, followed by another pediatric ortho fellowship in Cincinnati. And sir has done a fellowship in deformity correction from South Korea. So sir is also the recipient of the best paper from the Korea University during one of their conferences. So thank you for sparing your time for us, sir.
Yes.
And Kamlesh, many of you might not know, but he is a teacher and a guide for the Sri Ravi Shankar, and I have learned a lot of spiritual things from him. So he's always smiling because of his those characters. So this Kamlesh, please, enlighten all of us.
Thank you, Molin Bhai, for kind words. Thanks, Meet, for a nice introduction. See, Molin Bhai ने इतना बोला तो मेरे को भी Molin Bhai के लिए थोड़ा बोलना पड़ेगा ना. So Molin Bhai is such a guy. I have a rare combination of good surgeon and good academician. So thanks, Molin Bhai. You are one of that person. So thanks, Meet.
Thank you.
If you would like to share your screen.
Yeah, like. So am I audible and my screen is visible? Né?
Yes, sir.
Okay. So good morning, friends, and very great morning. It's Saturday morning. So for in a clubfoot, we all know the basic principles of Ponseti technique. But so how to get better? उसमें भी और क्या better कर सकते हैं? Let's see some few couple of things. My slide is not moving.
So the arrow at the lower left bottom, you can press that arrow.
Just a minute.
Yes.
Okay, fine. Now.
Yeah. Yes.
So there are in clubfoot, there are so many severity and very bad deformities. But the failure of treatments are more often related to the faulty techniques of manipulation and application of the cast. So even though there are severe deformity, but your techniques of manipulation and technique of cast are fine, then results are good. So how we can improve in this manipulation technique and application of the cast? I know the basic principle you all guys, you know very well. So in which things we can improve, like manipulation technique, casting, where to do tenotomy, when to do tenotomy, and what are the ideal bracing protocol. So there are 4 pillars. If we can so we can improve in these 4 pillars, and we can better in a casting technique and manipulation technique. So one by one, manipulation. So what happens in a, see what we do when we abduct the foot. So these are the most common error. Even I started my pediatric orthopedic practice. Before that, I also do the same maneuver. Have you seen this maneuver? If there is a clubfoot, and what we do, we abduct the foot. But while abducting this foot, have you noticed that? What happens actually? So this is a pronation. Pronation is going on, that increases more chaos and it locks the calcaneum. So if you see the subtalar kinematics, if you understand the kinematics, the abduction of the foot and your heel should be swing its on. So, but the pronating of the foot ultimately we increases the cavus and we lock the calcaneum, and that leads a rigid foot. It's a very common problem. So what actually we have to do, the correct technique is, if we see the cave, we have to correct the cavus first. Okay, the what done in cavus, you have to lift the first metatarsal head. What happened at the time? Once you lift the first metatarsal, the whole metatarsal head in a same single plane. So that is called supination of the foot. So manipulation in the first key, we should not do a pronation of the foot. We have to supinate the foot. And simultaneously, if you are correcting the further abduction, the abduction should be in a single plane. You have to abduct the supinated foot, not a pronated foot. If go for a pronation, that will block your calcaneal movement and increases the cavus, and that leads a rigid foot. That is very important. So very important key, always manipulation in a supination. The second key point is, see, where we know that we have to put our thumb. So where we have to put our thumb, we all know that. But again, here there is a technique. See what happens actually, the talus is usually how we will identify the talar head. So when you palpate your thumb over the lateral aspect of the ankle joint, so what, that's the first bony prominence. See, this is the first bony prominence. This is your fibula. This is the first bony prominence is fibula. Now just go anterior and superior, then you feel the first bony prominence, that is your talar head. What happens actually, it is more anterior than expected. So this is very important. Otherwise, where your thumb put over calcaneocuboid junction, and then what happens? Once you put thumb over the calcaneocuboid junction, again your subtalar kinematics, it will not work, and your swing of calcaneum will not proper. So it's very important. You have to give a counter pressure on the talus. Another thing, when we give a pressure, it should not be too wide area. It should not be too less. When you put a thumb here, so it is not wide, like it's not a full your distal toe. Otherwise, what happens? So this is the technique. So this is, you have to just palpate and abduct the talus. Now the third thing is, in manipulations, we have to abduct the foot. Why abduction? There is a lot of questions. So this is, we understand this subtalar kinematic. This is very important. See what happens once you abduct the foot. You can see here your heel goes evert and dorsiflex. You know this one. So this is very important in a Ponseti principles. You have to abduct the foot, abduct the supinated foot. Once you abduct it, your heel will convert. But again, how much abduction is needed? Because sometimes during your treatment tenure, when your foot looks normal, at the time you just directly go for a tenotomy. But the things are why they put a 60 to 70 degree abduction. This is very important. The reason is, once you abduct foot up to 70 degree, then and then your whole posteromedial structure, soft tissue, the structure, they get stretched properly. That is the first reason. And second thing, once you abduct, you can see here, up to 70 degree abduction, then and then your heel varus should be properly corrected. It properly everted. Then and then it will correct. So manipulation should be given up to 70 degree. You can see here that the foot is up to 70 degree abduction is there. So manipulate up to 70 degree abduction. That is very important. So this is also a very important thing. While manipulations, we should not try to do a forceful dorsiflexion. So there are a couple of, in my initial practice, there are a couple of cases I faced this problem. We couldn't understand the proper principle. So what happened? If we correct the equinus before your varus is not corrected properly, that all your pressure will go to the Lisfranc and midfoot joint against your TA is tight. That leads a very bad deformity. It's called rocker bottom foot. So your foot become rocker, your foot become complex, and there are high chance of relapse because your calcaneum will still not properly corrected, your heel varus is not properly corrected, even though we are trying to correct the equinus. So try to avoid during manipulation or during casting, try to avoid your forcible dorsiflexsions before your full varus correction is achieved. So some of my manipulations, always manipulate in supination, abduct your supinated foot. This is very important. Otherwise, your heel varus is not corrected. The most of the time, relapse and recurrence or rigid foot. The main reason is we have to abducted the pronated foot. Supine is not properly achieved. That leads to very bad rigid foot. Counter pressure, yes, always on a tailor hat in a proper manner. It is not like that. It should be a properly laterally. It is more anterior than expected. Keep in mind that. Yes, abduct, abduct, and abduct. We have to go for a T8 anatomy or equinus corrections once our foot should be 70 degree, at least 60 to 70 degree abduction is must. And please try to avoid forceful dorsiflexion. So these are the basic tips in manipulation. Now the second pillar, how can we improve in second pillar, like a casting, technical, molding, and padding? So what happens, that, so most of the time when parents come with a plaster in bag, the reason is because it's too much padding. So we are aware of that, or we are afraid that if it's a less padding, then chances of sore is high. But if you put a high padding, there are high chance of cast slippage. And second modality is the molding. If your padding is first class, but your molding is not good, then again there are high chance of slippage. Once cast gets slippage, and you know that after first class or third class, cast gets slippage. So again, foot remains for a couple of days without plaster, that leads to rigid foot. So very important thing, too much padding or too little molding, that leads to cast slippage. So what we have to do in a proper molding? So when we apply cast here, you can see here. So what I do, make a good foot plate, apply a cast here. While applying cast, your hand should be moved properly. So it's a proper, there is no counter pressure there. So this step is very important now. So this molding, that gives a very good stability of posture. So your heel is properly molded, and your cast slippage chances become very less. So we can improve here by doing a good practice, and parent must be vigilant for that. The second thing is, in casting, we know the casting technique, but see, if in initial, when I apply plaster, most of the plaster length will be mid-thigh. It should not reach up to the groin. So what we have to do, so apply your padding from up to the groin region, more 2 or 3 turns over the groin. So that will, so whenever your soft padding is there, then definitely your plaster will not be short. So what happens if there is a short leg cast? So if there is a short leg cast, definitely there are chance of cast slippage. Again, cast slippage leads to rigidity. And if there is a short leg cast, your calcaneum will not hold properly. Molding and length of cast also matter. So the length should be from where? From toe to groin. It is not from toe to mid-thigh. It's up to the groin, it should be extended. That's very important. Now you apply your cast, you will learn that if you not apply it up to the groin, there are chance of slippage of cast is more. So this is very important. How to remove the cast? See, 2 questions. When to remove? So there are a couple of practitioners. What they do, they ask the parents to remove the plaster at home and come on the next day. But what happened? Your patient come from I think 10 hours or 12-hour journey, and without plaster 10 hours, that leads again the soft tissue will not properly stretch out when you apply a cast. So better to remove on the same day or at your clinic. Again, there is a paper shows if it is removed, timing of remove, the correction is good. If it is removed at your hospital or your clinic. So this is very important. Generally, we prefer removal on the same day. Another thing, how to remove. So in a hurry, our pediatric orthopedic OPD, what we do, sometimes we remove the plaster with plaster soap. But it's not ideal thing because skin is so sensitive and your padding is thin because you are doing a very well padded and well molded cast. Your padding is very thin. there are high chance of skin burns by scope. So don't use a power saw. What we do, we make a marker here. Have you noticed that? So what we make a marker here, and these are the distal end we make little bit thick. That is called knot of plaster. So what I do in a foot plate, so if you complete the cast, that is very easy to identify your cast knot. So soak in warm water and do unwrapping of cast. So that is the best technique in a removal of cast, and that is very important. So whenever, suppose if you cut by a plaster saw and that leads a plaster burn, and what happens, you could not apply the next cast, and that leads again a rigid foot. And it's the result will be very difficult in a this Ponseti technique. So again, we do a casting if child is agitating, child is crying, completely moving his or her limb, that leads a poor correction, because when you move at the time, plaster is not get set properly, and at that time foot is moving, that there are chances of cast broken is very high, and that is a poor correction. So child should be properly rested, well fed, and not agitated. That is the first thing. Use of general anesthesia. Most of the time, I don't use general anesthesia, but sometimes after 2 years, again we are using the same principle, again the same casting technique. At that time, child is not cooperative. Sometimes you can use it, but in a fresh or a virgin clubfoot child, there is no use of general anesthesia, because there are high chance of too much pressure. Too much pressure, you don't know, because crying sometimes gives the idea that now we have to stop it for a correction. It leads a overstretching of the tissue. Again, it leads a rigidity of foot. So comfort is very important. You can try music, some toys, or with after feeding. So there are your creative ideas you can use. That child should be properly rested. It is not agitated while application of the cast. So some of my casting technique. So it's a properly molded, well padded. This is very important. Your varus mold that to prevent your cast lipid, that is a very important thing. While applying a cast, you have to take care that it's a toe to groin. It is not a mid-thigh cast. It's a toe to groin cast. It is not a short leg cast. Removal of cast is very important, because if there is a damage over the skin, again you can disturbing your complete tenure or complete journey of your cast clubfoot correction. And cast should be given in a proper comfort. The third pillar is, we know that tenotomy. So there are a couple of questions: when to do, where to do, and how to do. So let us discuss when to do. If it should not be done prematurely, as we will know that it should be properly abducted the foot. So the first indication is it's a completely abducted foot, at least 60 to 70 degree abduction. Then and then your calcaneal will move. Otherwise, your calcaneal will not move. Second indication is less than 10 degree. See, once you correct the foot and you check your dorsiflexion, it is less than 10 degree. So there are two indications for a tenotomy. It should not be prematurely. Before that, it should not be performed. Completely abducted foot, and then you go for a tenotomy. Now, the second thing, where? Then it's a very important thing, not too low and not too high. If you go below, then you can damage your calcaneal cartilage. And again, there is a poor correction. Your equinus will not be corrected. So it should not be low, too low. It should not be too high, because if you go higher, then it is not a tendon. You enter in a muscular part that leads a incomplete tenotomy. It is not a complete tenotomy. Again, it's incomplete. Then you forcefully dorsiflex. So your correction will occur at the midfoot, not at the ankle joint. Your equinus is not corrected. That's a midfoot crack, and that leads a rigid foot. So keep in mind that it's not too low and not too high. Just 0.5. You feel the calcaneum part. You feel the high cord-like structure. That's a 0.5 centimeter. Depending the baby's foot is not like that. It is a 0.5 or 1 centimeter. It's a foot size, but you can feel that this is your hardest and tendon part. Now how? Again, it's very important. If it is incomplete, tendon will not lengthen and it leads to midfoot break. So it's a complete tenotomy. Here there are surgeon's choice. What in my practice I do percutaneous sternotomy. I don't do open sternotomy, and I do a local anesthesia, and I use a 18 gauge needle. And but when you do a practice for that, then but very careful, but it should be complete. Even though you do a percutaneous sternotomy, very careful that your tendon is completely cut. You can feel the pop sound. You can feel the deepened part. So it should be complete. So it depends on surgeon's choice. Somebody will go for incomplete percutaneous sternotomy, or some surgeons they prefer a open sternotomy, open, or you can use a 15 number knife in your cut. And but it should be the things are it should be complete sternotomy. The fourth thing in sternotomy, very careful about neurovascular injuries. Because I have seen in one case when you cut the posterior tibial vein, and then it leads a huge hematoma. I faced one time in my practice. So very careful. If you go too medially, there is a posterior tibial artery. You can damage the posterior tibial artery. If you go too laterally, there are small saphenous vein, and that also give a problem. So very careful about sternotomy. To sum up my sternotomy, should be right time, not be prematurely. Properly abducted foot, less than 10-degree dorsiflexion, then definitely go for a sternotomy. Right location, not too high, not too low. Right technique, it should be complete, whatever technique you use, it should be a complete sternotomy. And beware of neurovascular structures. So this is a third pillar. And fourth pillar, how can we improve the compliance? So foot abduction brace. So that you know that prevent relapse after removal of the cast. Foot abduction, there are many designs are available. Different choices, but the principle is you have to abduct proper to maintain the maintenance phase. So what are the ideal principle? Border high top open toe shoes that are attached to the end of adjustable aluminum bar, and the distance of this heel of the shoe that is equal to the width of baby's shoulder. That is very important. Otherwise, you're kicking and it will be not proper. And your toilet and cleaning is also not, it will be difficult. So distance should be shoulder apart. The shoes on a club foot, it's outward rotate 70 degree. External rotation require, already we have given abduction of 70 degree. So an affected foot, it should be 70 degree, while in a normal foot, if there is a unilateral foot, up to 30 to 45 degree. What is the protocol ideal? That depends your surgeon's choice, but ideal protocol is the brace is worn up to 23 hours a day for at least 3 to 6 months, night time or during nap time for up to 4 to 5 years. So this is the ideal protocol. So how can we improve that? You know that the relapse rate 78% in a non-compliance family. If baby is not comfortable, family is not properly educated about FAB, there are high relapse rate. You know that in initial Ponseti initial paper in 1962, the relapse rate was 80% in his paper. The reason is only there is a foot abduction brace. So if there is a compliant family, the relapse rate is very low. So how can we improve the compliance? So this is very important thing. We have to educate about foot abduction brace, because once we apply the foot abduction brace, baby will go home. So we have to educate everything. So generally what I do, I spend at least 30 minutes and my staff will spend 30 minutes proper learning for that, how to wear it. So education is very, very important. First, we have to understand how to apply, then we have to educate the parents. The second thing is, see, suppose if you are using this type of braces, what I do, you have to apply. Very important thing, you have to always apply thin socks with open toes. The toes should be open. You can know that your toes is fine. It is not compressing anywhere. That is the first thing. Always apply very thin socks. Otherwise, that leads a shoe bite and ulcers. That is very important. If you are using such kind of braces, then definitely apply the middle strap first. The things are, you have to stabilize the ankle. Once you stabilize the ankle, then it is very easy to apply the other strap. Fourth thing, you have to educate about the heel. So in this type of assembly, we have a hole on that. Then you can see, you can check the heel. The heel should be properly touched to the foot plate. The first recurrence is an equinus. So you have to educate the parents that heel is off, then definitely you have to come urgently. There are some fault if you are faulty techniques of your wearing, or there are early recurrence of equinus. So this is very, we have to, the things that we have to educate properly. So I summarize my talk. In the manipulations, abduct well, but abduct your supinated foot by a proper counter pressure on talus. That is a very important key. If we only learn this technique, then definitely our skill should be definitely sharper. Second thing, cast, it should be toe to groin and use a proper molding and very thin padding in a comfortable environment. So this is very good conditions, properly mold, and it's a toe to groin cast. Tenotomy, it's not too high or not too low. Whatever technique you can use, but it's a complete tenotomy. And bracing, the only thing is how to improve compliance. It's a compliance and only compliance and only compliance. If your bracing compliance is good, if you are spend 1 hour in your initial time of your bracing, that will be your happy ending. Otherwise, there are high chance of recurrence if you're not properly applied bracing. So thank you very much for your kind hearing.
Thank you very much, sir. That was a very comprehensive review of Ponseti technique. So we have a few questions, and if anyone else has any questions, kindly put them up on the chat. So one question that I had, that
Yes.
is there any role of Pirani scoring? I mean, do you use it in your routine practice?
Yes. Always, because there are two things. You can know the documentation. That is the first thing. We all do a Pirani scoring in all cases, and documentation is very important. Second thing, you can know the prognosis. So your first cast is doing good. Your score is from 6 to 5, 5 to 4. So you can know the prognosis. And third thing, definitely you can check the numbers of plaster also. That is the third thing. And also there are a couple of papers, if the score is more than 4.5, so you can know that that patient required tenotomy. So in initial your counseling, you can explain tenotomy also to the parents. So definitely Pirani scoring is very important, this all 4 criteria.
Okay. And sir, does it change the management assess? Like, does the duration, does the timing of tenotomy vary as per the Pirani score?
Not timing of the tenotomy, but you can know that. See, there are papers about 4.5 score is there. So the probability. See, in private practice, what happens? See, once you explain clubfoot management, you have to spend some time. So tenotomy is a one kind of surgery. So if you have to explain surgery at the end of 4 to 5 plaster, then it will be in Indian scenario, it is difficult. But you explain in each and there is 5 to 6 plasters, and then very small surgeries may require. So you can probably, after doing the Pirani scoring, you know that tenotomy may require. It will be easy for a counseling.
We have another question by Dr. Sheenam Bansal. She has, sir, could you please share the paper that you mentioned, the effect of cast removal timing?
I will send to you.
Sure. So we have another question by Dr. Raman Srivastav. Dr. Raman Srivastav, how would you counsel the patients who request to keep the cast a little distal to the groin for hygiene purposes? What do we tell them, sir?
Yes, I always do a casting, apply a plasters in a diaper. And during cast also, there is always you have to wear a diaper. That is the first thing. Second thing, so you have to change the diaper every time. Whenever the baby they make it wet, there are chances of skin erosion and the problem. So always wear a diaper. That is a very good key. And the second thing is, up to apply, you apply more soft padding over the groin also. So ultimately, when you apply a cast, it goes down. So if you apply a little bit more over the groin, it will go to just to the groin region. So there are two things: is very apply proper padding over the groin and always use a diaper. Yes, mate.
Okay. So another question that I had: if we have performed a tenotomy And there's a lot of bleeding from the tenotomy site. I mean, we have not gone medially, but there is a lot of bleeding.
Bleeding.
So, is there, I mean, do we need to use adrenaline, or do we need to do something else, or just pressure?
No, just press it. I don't use adrenaline. So what I do, see in chubby child, what happens? So when you inject local anesthesia, there is a bulging. So there will be difficulty to identify the tendon part. So what are the practical tips here? What I do, so first you have to identify, because before giving a local anesthesia, the heel cord is so tight, you can feel nicely. So take a local anesthesia, and where to do her tenotomy, inject that site. So when you remove that needle, there is some bleed. Okay, so this is your entry point. So I do a percutaneous stenotomy. I use 18 gauge needle, but I use the same entry point where I put my local anesthesia.
Okay.
And whenever there is a bleed, so the things are, we are orthopedic surgeons. We have a lot of hurry. So proper anesthesia, wait for a couple of minutes. Otherwise, what happens? Your local anesthesia effect is not going on, and we go for a tenotomy. So again, here passion is very important if you are treating a clubfoot baby. Okay, and when there is a bleed, press it for at least press for 5 minutes. There is nothing harm in that. That's very simple. I don't use adrenaline.
Sir, once the patient has the tenotomy is done and the cast has been removed, so once they have been given a brace, how frequent should we call them for follow-ups?
Yes, initially, see here a change of routine. My follow-up is different, because you never know. Initially, if FAB is not properly comfortable, and there are chance of recurrence. So in initial my practice, initial first after 1 month. Once your foot brace is ready, they learn properly. Then I call after 1 month. Again, we will check. Again, we will score, assess. Then everything is fine. Then I will call for a 2 months or 3 months. Then depends on patient's condition. But first FEB, the first visit, it should be after 1 month.
Okay, sir. So now we have a case presentation by Dr. Sheenam Bansal. So, ma'am, if you would like to start your presentation.
Okay, this is a case of a 1-month-old infant presented to another center with this deformity. He had there were 4 plasters were applied for this deformity elsewhere, and there was history of multiple plaster slippage and skin breakdown. Then he presented to us at 2 months of age. We can see here all metatarsals are in equinus. There is hyperextended great toe, high cavus is there, puffiness of the skin is there, and deep plantar crease on the plantar aspect. And there is mild valgus at forefoot bilaterally. And there is hindfoot and forefoot equinus. So these are the x-rays. This is a lateral view, and we can see metatarsals are in equinus and calcaneum in equinus. So this is something atypical, which we usually don't see. These atypical characteristics of some patients of club feet were described in 1994, firstly by Professor Turpo in this book, The Clubfoot, the Present and a View of the Future in 1994. So what lead this deformity from this deformity? The reason is failure to recognize weak supinators and tendinous tendoaquilles up to an upper third of the calf might lead to this deformity after application of typical Ponseti plasters. Now, how we should treat this? This is a paper was Ponseti sir, treatment of the complex idiopathic clubfoot in 2006. It was published in 2006 in Clinical Orthopaedics and Related Research Journal. He has described 2 thumb technique Metatarsals were extended, and hindfoot and forefoot equinus was corrected simultaneously. Two thumbs were kept under the metatarsal heads and were pushed the foot into dorsiflexion, and mild metatarsal hyperabduction was given. Knee was flexed in 110-degree position to prevent the slippage of plasters. In their study, there were 50 feet, which were 75 feet of 50 patients who were atypical and were treated by this technique, two-thumb technique, and 5 casts were applied on average, and average age at the follow-up was 23 months. They saw the 7 relapses, and second relapse was seen in 2 patients. Average time of first relapse after correction was seen after 1.5 months, and second relapse was seen after 3 and 6 months. And then they changed the foot abduction brace for complex club feet. They decreased abduction, and there were these holes were the brace was molded. These holes were created to see the hindfoot alignment position of the hindfoot in brace. And after using this brace, they didn't saw any relapse. We also used this technique, modified two-thumb technique. This is a video. All metatarsals were extended simultaneously with both thumbs, while forefoot in mildly abduction. Heel also is dorsiflexed and slightly abducted. To correct heel varus, hindfoot is abducted with counter pressure applied not only to talar head but also to lateral malleolus. With middle finger, heel is pulled down. That is called heel pulling maneuver. And plaster was given in more than 90-degree flexion to prevent slippage of the plaster. We need to check here the blanching of toes, because in some cases of atypical club feet, there may be absent dorsalis pedis artery. This is a 6 months follow-up of this case. We can see there is well-corrected feet. This is 12 months follow-up, and this is 16 months follow-up. So in summary, complex clubfoot needs modified two-thumb technique to achieve complete correction, and its early recognition is very important. So what's your view on complex clubfoot? Yes.
So Sheenam, is a nice case, and there are a couple of questions. So that's a modified two-thumb techniques. What is the difference in your this modified two-thumb techniques in the original Ponseti technique? Kindly highlight some points for that.
Sir, in this technique, in modified two-thumb technique, we simultaneously are correcting forefoot equinus and hindfoot equinus. And the other difference is, as in complex club feet, the calcaneum doesn't rotate easily. So we will not give more abduction, forefoot abduction. And the next is, whenever we are correcting hindfoot varus, we will not just consider talus as fulcrum. We will also consider this lateral malleolus as fulcrum. Lateral malleolus plus talus. Calcaneum, the thing is, in complex clubfoot, calcaneum is not getting rotated easily as in typical club feet. If we will try to rotate, try to abduct more, and we can have midfoot break. And in this technique, in typical Ponseti technique, we don't touch heel. Heel is not touched, but in this technique, we are correcting hindfoot equinus and forefoot equinus simultaneously.
Yes, and another thing, sometimes if you are treating a complex club foot, so even though you pull and a two thumb technique, the deformity will not correct. So sometimes you go for a early tenotomy for that.
Yes, sir.
So
Incomplete.
yeah,
Yes.
just go for an early tenotomy, and sometime you go for a plantar fascia release also. That will help also, because your forefoot will completely, even though you put a press, and it will not get correct. So you go for an early plantar release and early tenotomy. In ideal Ponseti technique, we go for a tenotomy at the last. But whenever we are treating an atypical club foot, we'll go for an early tenotomy also. Yes.
Yes,
Sir, I have a question, sir.
Yeah.
Would it be correct to call complex club foot as iatrogenic? I mean, we know that there are weak supinators, but
See, in this case, I don't know, but initially you look, if you go for a Pirani scoring, or you just examine the foot, you feel like that's a typical club foot. Once you apply a first cast and it is not responding, it is like that. So your leg and it's a complete equinus. So you have to identify it. See, this case it might be iatrogenic, but atypical club foot, it is already there without iatrogenic. Yeah, it is there. It's atypical. So it is a very warning sign. You have to identify this is a atypical club foot, and you are treating atypical club foot, because all the protocol Ponseti is completely changed, and you need more plasters. You need a different DBs, different bracing. So become very careful if you are treating atypical club foot.
sir, and we have a question by Dr. Raman Srivastava. Have you found the Steenbeek brace to be as effective?
Yes, it is as effective. Yes, yeah, it is as effective, because that I told. The principle is foot abduction brace. So whatever you want, you can use. It's a surgeon's choice. It is as effective. But I use it's a different FAB.
Okay. Okay. So shall I proceed with the next case, sir?
Yes, Meet.
Okay. So I will be discussing two cases. Both of them in the Ponseti method have been used in the walking age group. So we have a 3.5-year-old who presented with this neglected club foot. I mean, it has been the patient has not taken any treatment so far, and we have another 6.5-year-old who has come with a similar presentation. So in such cases, how would you like to proceed? So we usually at this age group, when the patient is walking 3.5, 6.5, we have three commonly used options: limited soft tissue release, or a conventional PMR, or a fixator assisted correction. So should we use one of these three, or should we use something else? So what we thought of was, can we employ the Ponseti technique for these? So this was a paper published in the Annals of Transfusion Medicine in the year 2021 by Christina Alves et al. So first, what they did was that the term neglect, they mentioned that it had a negative connotation, and these cases of neglected club foot were usually seen in the low-income countries with poor healthcare. But the neglect part, the neglect part was probably not true, because the problem was in finding the adequate healthcare provider and not neglect from the parents. So they proposed the term as a walking age club foot, and they have mentioned that these feet, since the ossification already started, these feet are usually stiff to start with, and so the aim of the correction should be to achieve a plantigrade foot, and not the focus should be more on plantigrade and not flexibility, as is the usual case. This was a paper published in the Iowa Orthopedic Journal in the year 2020. So this was a multi-centric study conducted in 7 countries, 15 centers. From India, we have Dr. Alec Arugis sir's name in this paper. The center was Bijlani. So all the feet were assessed pre-operatively and post-operatively with Pirani score and an outcome classification, which was given by Nojura et al. So the classification that they used, the outcome classification, was based on passive ankle dorsiflexion, residual deformity, and residual pain. So this is how they described the outcomes. They described it in easily understandable terms as great, good, regular, and poor. So if the foot was plantigrade, which is our main goal, and there is at least 10 degrees of dorsiflexion with no deformity or pain, that was the great result. For a good result, we need to have at least from 0 to 10 degrees of dorsiflexion with no residual deformity and no pain. Poor results would be when the initial correction has failed and the patient requires extensive soft tissue release. And a regular result they described was there was residual deformity remaining, but however, there was no pain. So based on this, they conducted a study, and the results they found were that 87% of such feet could be well corrected with the Ponseti technique. And one patient in this series was as old as 26 years. So the mean number of casts that they had was 6.8, and the relapse rate was significantly high at 31%. On further examination of these relapse cases, they found that they were associated with two main factors. That is age less than 4 years at treatment onset and bracing non-compliance. This was another article published in JBJS 2007. It was published by Lorenco and Mosso, and they proposed modifications to the Ponseti method for these neglected club feet. So they said that the manipulations, since the foot is a little more stiff than what it is during infancy, they proposed longer lasting manipulations of around 5 to 10 minutes. They proposed 2 weekly cast change and not every weekly. The abduction was reduced from 70 degrees to up to 30 to 40 degrees. And the Ponseti foot, the normal foot abduction orthosis that is used was not tolerated by these children of the walking age. So they proposed AFO, which is to be used full time for 12 months. So this is what we followed. We followed the Ponseti method, and in the child, in a 3.5-year-old child, this is the well corrected feet. In the 6.5-year-old, we again had a similar good result. So to summarize, 4 things that need to be done differently from idiopathic CTEV. Plasters are to be given under GA. Plaster change is done every 2 weeks. Since these children will not tolerate the FABs, the AFO that is to be prescribed should be worn for 1 year. And in case the percutaneous TA tenotomy fails to provide adequate dorsiflexion, we had to perform a posterior capsulotomy. Thank you, sir.
So Meet is a nice presentation, Meet, and it is a very good concept, Doctor. I think Matthew Varghese in Delhi. I think you heard the name.
Yes, sir.
So he definitely apply Ponseti cast in, even though there is a 10-year untreated or 12-year untreated. That is a very good. There is a all your 4 the modification of the Ponseti cast. There's really wonder that it works very well.
Okay, sir.
Yeah, any questions?
I don't think there are any questions.
So what the little bit difficulty in a institute-based practice or in a private practice? I will give some highlights of the private practice of that. Suppose patient came to us after 6-year untreated club foot, like in your second case. So if you explain that every time we will give anesthesia, every time we will give a cast. So it little bit difficult. It is not, I'm not telling any against about this article or technique, but it's a counseling for that casting and walking child. It is very difficulty to maintain in a cast for, suppose you apply a 5 cast in your paper, approximately 5 to 6 casts. So 5 multiplied by 2 weeks. So it's a journey of 3 months. Okay, so it's little bit difficult in our Indian scenario, village scenario, but it works nicely. What I do in untreated clubfoot, you already mentioned that. So your aim and objective is completely changed. The reason is, see, once you're a flexible, our aim was 3 aim. It's a flexible foot, it is a painless foot, or it is a plantigrade foot. But once you are treating a untreated clubfoot, your two aim objective is changed, because your foot become deformed, your bones become deformed. Then our aim is only to get a plantigrade foot. So when I explain as a counseling, when we are treating untreated clubfoot, the main aim should be the plantigrade foot. That is the first principle. Second thing, definitely you can use a different techniques. You have mentioned 3 techniques, and this is the 4th one. So another one, there is a a la carte procedure. I think you heard about that. So there are multiple whenever you go for posterior tenotomy, soft tissue, there is called a la carte procedure. You can use a la carte procedure, and I am a fan of whenever I treat as a neglected or untreated clubfoot, I use fixator. Because it is the same principle you are applying, like it's a stretching of the soft tissue by plasters. But once you apply a fixator, it is the same skeletal traction by following the same principle. So it is also works wonder, but that depends totally is a surgeon's choice. A patient came to me as a 8-year, and it is very difficult to explain every 2 weekly cast for 6 to 7 cast, and then 7th surgery for a tenotomy. So 7-time anesthesia, it's a long procedure. So I prefer a JES. Any questions from you guys?
Sir, if we use a JES, then how? What is the usual duration of a fixator for sitting?
See, again, there are 2 phases. One is a corrective phase. Most of the deformity in a clubfoot, there is a 4 to 5 weeks that needs correction. That's a 4 to 5 weeks for a corrective phase. Then different choice. I prefer 2 weeks for a consolidation phase. I stop the distractions. Then after 2 weeks, I will remove the JES and I will apply a cast for at least 4 weeks.
So there are no further questions. If there are any questions, sir, I'll forward them to you and we can discuss it on the fellows group.
So what in your Orthokids, what you prefer in an untreated clubfoot?
So for untreated, sir, we usually the 4 things that we used, that is what we usually follow. So
and what are the practical? Have you faced any practical complications, like the counseling is different, convincing the patient is difficulty? Any difficulty you face? Because when I met Matthew Varghese, he strictly recommend you to go for a Ponseti. But have you any? I face so many problems. You have explained for a casting and multiple anesthesia in your Orthokids. What is your experience?
in the last 6 months, I mean, we have done Ponseti for if there are like relapse cases where the type 3 relapse, where all the deformities have relapsed, then we perform a cuboid decancellation and the full entire procedure, tiband transfer and open Z lengthening.
So also you following this a la carte procedure, not this Ponseti.
Yeah, if yes, if there's a type 3 relapse, then that is okay.
Okay, good.
So one comment from my side.
Yes, Deepak. Deepak.
Whenever we are using JES, so you can't get that rotational component as we get in Ponseti's correction, that talonavicular correction, because in JES, just a linear distraction of the soft tissue, and it's not the rotational component which we get. So what I prefer is, if the child is above 6'7", I prefer to use Ilizaro instead of JES, because with Ilizaro you can give that rotational component as well. What is your experience like? If you have got the X-rays in these kids, have you got that tendinonavicular divergence or tendinonavicular correction, which we generally get in Ponseti. What's your comment?
See, Deepak, yeah, it's a good option. Elizaro is definitely it's a good option, and but the things are, see, Jess came into the picture with an option of Elizaro. The reason is there is a differential distraction. Okay, there is a medial distraction later, and the difference are the distractions rates are different. So you telling that yeah, there will be more in Elizaro. There are hinges, then definitely you can correct on the basis of hinges. But if you follow good differential distraction in convex side and concave side, there will be no rotational, as per my experience. I don't know. And the things are here again. We discussed that your aim and objective in an untreated club foot, it's totally different. You want plantigrade foot. You will not get a. But definitely, but the things are in Elizaro, it is little bit lousy, and that's why the Jess came into picture. So I regularly Jess. Yeah, you are right. It's a special, more, suppose 8-year child and heavy child, body is heavy, weight is heavy, then definitely Elizaro is a very good option.
Sir, what is your experience after fixator removal? Do you go for lateral column shortening or CC fusion in older kids each and every time? Or
after Jess removal? So there is after Jess removal, I give a cast because your whole foot is abducted. What I do, because I want at least you could not correct up to 70-degree abduction. That is very important thing. So my cut point is 30-degree only, because my aim and objective I have limited if you are treating untreated club foot. So 30-degree abduction is more than sufficient. I don't think so. Some cases, if it is there a significant in-toe progression, most of the time what happens, it is because of it is not foot abduction. The most of it's a tibial inversion, tibial torsion, because it takes long time to correct. So in few cases in my Jess, after the correction of all the deformity, 5 to 7 years, still there is a inward movement. Then I go for a tibial derotation osteotomy. Most of the time, it is because of tibial torsion.
Thank you, sir.
So Deepak, you use a ala carta and Jess. Suppose some patients came with untreated club foot after 6 years. So what is your preference of choice?
My preference is to start with straight casting without GA.
Okay.
1 or 2 casts, and when I get that pliability, because patients' compliance for repeated visit in an older child is very difficult, as you said.
Yes, it's very difficult.
So
yes.
I go for after 2-3 casted. After 2-3 casting, I go for limited PMR.
Okay,
and
so that is called
plus minus demand, because in our practice it's very difficult to ask the patient to get admitted each and every time for GA every week, and for 3, 4, 5 weeks, and still we are not sure if surgery will be needed or not.
Not.
So
yes.
I better prefer to do a limited PMR after 3-4 casting without GA. So 1 surgery overall.
So you use a a la carte procedure in your modified way.
Yes, and in those cases which are being previously operated, I prefer to do an Elizaro assisted correction with lateral column shortening at the end. So they require 2 surgeries, because I feel unsafe to go again medially. So that's why I prefer to stretch them with Elizaro and then go for that.
Yes, and have you observed that Deepak and Meet and all Seaman, everything? See, when the nowadays, see, we are treating club foot at early age. Most of the time we will reach. Untreated patients are getting lesser. But the relapse is getting more and more. What is your experience? See, even not our patients everywhere, the number of the iceberg of relapse club foot, if you see the horizon, the relapse club foots are the number is huge. Deepak, what is your experience?
Sir, since I've seen my patients also, there is the component of poor compliance and poor physiotherapy. But one more important component is overactivity of tibialis anterior, which generally we observe when the child starts walking. So in my practice, what I have observed is the relapse of supination deformity or dynamic supination is more in my cases. And those cases which being done outwards, they generally, what happens now in periphery and all, they do casting, they get all the correction, but they defer that tenotomy part.
Yes.
Because they think that it's difficult to give anesthesia and difficult to do that procedure. And because of that, the compliance for foot abduction cases is very, very poor in kids. So the cases in which I have seen relapse are those in which tenotomy was deferred. I don't know for what reason. Sometimes patients also, they try to like defer the tenotomy part because the kid is small and they feel the surgery is not surgery is unsafe, because I do tenotomy under GA. I don't do it in local anesthesia in my setting. So this is the reason in which I have seen the relapses on those.
So you're in a surgery, suppose I operate 10 cases of clubfoot, the relapse I operate 6 cases, 4 cases is free. It's a virgin foot. So relapse rate, operating relapse rate is more comparatively. Yes, Meet, any question?
No, sir. I think there are no further questions.
So thank you, Meet. Thank you very much. And your both cases are fine. Sheenam cases is absolutely fantastic, good learning. And thank you, Orthokids, for giving this opportunity to share my experience with you guys. So this is my best wishes for your bright future, bright pediatric orthopedic future. Wishing you best.
Sir. Thank you.
Thank you. Thank you very much, sir.
Okay.
Thank you for your time, sir.
Bye. Thank you very much. And see you. Bye-bye. Thanks.
Bye, everyone.
Bye.
Thank you, sir. I'll end the meeting now.